In this video, I am going to discuss about red flags for diagnosis of primary headache. If headache is worse in supine, disturbs sleep, or presents immediately upon awakening, or headache is triggered by cough, valsalva, bending and exertion, or headache is associated with visual obscurations, transient changes in vision with change in posture or valsalva, or vomiting precedes the headache, or headache which is associated with projectile vomiting, that is without preceding nausea, or headache associated with papilledema, we should consider all the conditions leading to raised intracranial pressure, which are neoplasms, abscess, focal edema secondary to trauma, infarction, tumor, hydrocephalus, cerebral synovenous thrombosis, diffuse brain edema secondary to encephalitis, meningitis, diffuse head injury, subarachnoid hemorrhage, or idiopathic intracranial hypertension. Workup for these conditions should proceed with neuroimaging. If onset of headache is after the age of 50, the differential diagnosis includes temporal arteritis, mass lesions, and the workup should proceed with estimation of ESR and neuroimaging. If patient complains of first severe headache, the differential diagnosis includes intracranial hemorrhage, that is subarachnoid hemorrhage or intracerebral hemorrhage, or bleed into a mass, or AV malformation bleed, or there could be mass lesions. So the workup should proceed with neuroimaging and lumbar puncture if not contraindicated. If patient complains of subacute worsening of headache, the differential diagnosis includes mass lesion, subdural hematoma, CSVT, or medication overuse, and the workup should proceed with neuroimaging and thorough medication history. If patient complains of headache associated with known systemic illness or systemic symptoms like fever, neck stiffness, the differential diagnosis includes meningitis, encephalitis, systemic infection, collagen vascular disease or arteritis, and the workup should proceed with neuroimaging, lumbar puncture if not contraindicated, and blood investigations for systemic infection and collagen vascular diseases. If headache occurs with abnormal neurological examination, the differential diagnosis includes mass lesions like infarction, tumors, or intracranial hemorrhages or vasculitis, and the workup should proceed with neuroimaging and blood investigations for the vasculitis. If new onset severe headache occurs during pregnancy or postpartum, the differential diagnosis includes CSVT, posterior reversible encephalopathy syndrome, or carotid dissection, or pituitary apoplexy, and the workup should proceed with neuroimaging. If headache is worsened in standing and relieved in supine position, the diagnostic possibility which should be considered is intracranial hypotension, and the workup should proceed with neuroimaging. If patient complains of thunderclap headache, that is time to peak headache intensity is in seconds to 5 minutes, the differential diagnosis should include subarachnoid hemorrhage, intracranial hemorrhage, CSVT, arterial dissection, or pituitary apoplexy, and the workup should proceed with neuroimaging. If the onset of headache is after the age of 50 years, associated with prominent beaded tender temporal artery and or jaw claudication, the diagnostic possibility which should be considered is temporal arteritis, and the investigation should proceed with ESR estimation. If new onset headache occurs in a patient with known malignancy, then the diagnostic possibility of metastasis should be considered, and the workup should proceed with neuroimaging and lumbar puncture if not contraindicated. If new headache occurs in a patient with known retroviral disease, a diagnostic possibility of opportunistic infection or tumor should be considered, and the workup should proceed with neuroimaging and lumbar puncture if not contraindicated.